All right, welcome to our clinical explainer on adult cataracts. And if you're a med student, a resident, or really any kind of trainee, this is for you. We're going to give you the high-yield stuff, the things you absolutely need to know for your practice. So just to set the stage for why this is so important, let's look at the sheer scale of the problem. Back in 2010, cataracts caused 20 million cases of blindness across the globe. I mean, think about that. That's not just a clinical problem. That's a huge public health issue. So yeah, this stuff matters. Let's get into it. So what even is a cataract? Well, at its most basic, it's just a clouding of the eye's natural lens. The best way to think about it is like a window that's slowly getting frosted over. It doesn't hurt, but it does get progressively worse. And if you don't do anything about it, it can eventually lead to total blindness. Okay, so when you're in the clinic, who's that classic patient that's gonna walk in with cataracts? And what's actually happening inside the eye? What are the big risk factors you need to be looking for in their history? So the whole process, the pathogenesis, it really starts with this kind of weird thing about the lens. It has this unique, you could almost say flawed design. Unlike your skin, which sheds old cells all the time, the lens can't. It holds on to every single cell it ever makes. So what happens? Over your entire life, these old cells just get squished, compressed right into the center of the lens. And eventually, they lose that perfect transparency and, well, they become opaque. That's your cataract. But here's where it gets really interesting. That natural aging process, it can get kicked into high gear by environmental factors. You definitely want to counsel your patients about two big ones, smoking and sunlight. And it's a direct dose-response relationship. It's simple. The more you smoke, the more UV light you get, the higher your risk, period. And of course, you've always got to look at the patient's medical history. Age is the number one risk factor, no surprise there. But you got to have a super low threshold to think about cataracts in patients with diabetes or anyone who's been on long-term steroids. And here's a really important pearl for you. HIV is also linked with getting cataracts earlier in life, so keep that on your radar for a younger person with vision changes. Okay, we know the risks. So how does this all come together in the clinic? What's the patient actually going to tell you, and what are you going to see when you look in their eyes? Okay, so the patient's story is going to give you a ton of clues, right? But it's your exam that really seals the deal. And you can see how the symptoms and signs line up perfectly. You'll hear this all the time. Doc, I can't drive at night anymore. The glare from headlights is just blinding. And when you hear that, you should be thinking, okay, I'm probably going to see a darkened or even a blocked out red reflex. Or they might say they need new glasses every year. That's that classic myopic shift as the lens gets denser. All right, let's get a little more specific because not all cataracts are the same. There are really three main types you'll see. First is the nuclear cataract. This is the classic one you see in older folks. It's slow, it messes with distance vision way more than near vision, and it makes colors look dull and faded. This is why you might have an 85-year-old patient who can still read the newspaper perfectly fine, but they can't see a street sign to save their life. Then you've got the cortical cataract. This one has a really classic look on exam. It looks like the spokes on a bicycle wheel, radiating from the outside in. But here's the key thing to remember. They can look super dramatic on your exam, but they often don't mess with the patient's vision as much as you think. And you'll often see these after some kind of eye trauma. And last, but definitely not least, we have the posterior subcapsular type. Now listen up, because this is the one you really need to pay attention to. Why? Because this one is fast. We're not talking years, we're talking months. It causes this awful, disabling glare, and it's the one you should immediately think of in a younger patient, especially if they're diabetic or on chronic steroids. So, you've made the diagnosis. Great. Next step is an ophthalmology referral for surgery, right? Well, yes, but your job as the primary clinician isn't over yet. There are some super important things you need to think about before you make that referral. Okay, this right here might be the single most important thing to understand about cataract surgery. The indication isn't a number on the eye chart. It has nothing to do with 20/40 or 20/80. The question is, can this person live their life? Can they drive? Can they read their medication bottles? Can they see their grandkids' faces? If a cataract is stopping them from doing what they need to do, that's your indication for surgery. Okay, everyone, lean in for this one. This is super high yield for your exams and for real life. If your patient is on an alpha-1 blocker, like tamsulosin, you have to know about intraoperative floppy iris syndrome, or IFIS. Your job, your critical job, is to tell the surgeon, and I cannot stress this enough, do not tell the patient to stop taking it. It doesn't really prevent the syndrome and can cause other problems. All you have to do is give the surgeon a heads up. That simple phone call or note can prevent a really bad complication. I guarantee you will get this question constantly. Do I need to stop my blood thinner for my eye surgery? And here's the bottom line. For most patients, the risk of having a stroke or heart attack if they stop their blood thinner is way, way higher than the tiny risk of a bleed during the surgery. So the general rule is to continue them. But of course, this always has to be a conversation with the surgeon. And here's a great tip that'll make you a better doctor and save the healthcare system money. For your average, stable patient getting routine cataract surgery, they do not need a bunch of preoperative tests. The evidence is clear. It adds cost and patient anxiety without actually changing the outcome. Just focus on a good history and physical. All right, so let's get to the good part, the results. What can you actually tell your patients to expect? What does success look like? And what are the potential bumps in the road? And honestly, this is one of the best stories in all of medicine. You can tell your patients with confidence that the outcomes are fantastic. In a patient who doesn't have other eye problems, more than 95%, let me say that again, over 95% will end up with 20/40 vision or better. I mean, that's good enough to drive without glasses. It is truly one of the most successful surgeries we have. Now, even with that amazing success rate, it's not a zero-risk procedure. The important thing for you to know is that complications can happen on different timelines. Right after surgery, you're worried about infection, endophthalmitis. It's rare, but it's an emergency. Then, much later, even months or years down the road, you have to keep an eye out for things like a retinal detachment. Okay, you are absolutely going to see patients who have had PCO, or posterior capsule opacification. The patient will come in and say, I think my cataract grew back. You need to be able to reassure them that no, it didn't. It's just a little film that forms behind the new lens implant. It happens to about 1 in 5 people. It's super common, and it's fixed with a totally painless 5-minute laser procedure in the office. Easy peasy. So look, the surgery is an absolute modern marvel. It gives people their lives back. But let's be clear, it's a treatment. It's not prevention. And that leaves us with a really big, kind of scary question. As the whole world gets older, the number of people who need this surgery is just going to skyrocket. So is the world's healthcare infrastructure actually ready for the tsunami of cataracts that's coming?